Let's talk about emergency medications every dentist should know, part 3. In this part, we're going to be talking about aspirin, nitroglycerin, and then the use of sugar glucose as an important emergency medication. We see the disclaimer, and we've talked about that in other parts of our lecture. I am Dr. Alan Schwartz, DDS CRNA, and I welcome you again to part 3. Here's an overview of what we've covered and what we're going to cover in the different parts of your emergency medications every dentist should know course. These are the main learning objectives for all 4 parts. We're going to talk about the way that the drugs are administered, what routes they're administered. We're going to talk about stocking emergency medications, the common medications, and you can see that we've been doing that with each of these parts. When to use these medications, what physiology they produce, their routes of administration, quick and dirty cheat sheet we're going to develop, and then again, emphasis on making sure you have fresh, up-to-date medications. So in this part, we're going to be talking about the basics of anatomy of the heart. We're going to learn when to use aspirin, nitroglycerin, and sugar glucose. We're going to review the physiology of the effects of aspirin, nitroglycerin, and sugar glucose, how they're administered, through which routes, and we're going to keep building your quick and dirty cheat sheet that you're going to keep with your emergency kit and your emergency medications. So before we begin the discussion of aspirin and nitroglycerin, let's just review some basic circulation and the heart anatomy. Notice that we've got the superior vena cava and the inferior vena cava emptying into what is going to be the right atrium. From the right atrium, blood is pumped and kicked into the right ventricle, and this is going to be called the low pressure side of the system because this is going to be pumped to the lungs, and the lungs just cannot see a blood pressure of 120/80. Pulmonary artery pressures are a lot lower than normal blood pressure. It will just tear the lungs up to have pulmonary hypertension, which is a really severe disease. So we've got that deoxygenated blood with carbon dioxide then going to the pulmonary arteries. Notice it's deoxygenated blood and it's going to an artery. Remember that the artery carries blood away from the heart. And again, that's the low pressure side of the system. Then blood is going to be pumped and returned through the pulmonary vein into the left atrium. It's oxygenated, it's lost its CO2, and we're going to then circulate it through the body. So it's going to go into the muscled left side of the heart. From the left atrium, it's going to kick blood down into the left ventricle. Look at the thickness of the musculature of the left ventricle. This is where you're going to be creating your 120/80 blood pressure. And then that's going to be pumped to the aorta and then to all of the major blood vessels and minor blood vessels and capillaries all throughout the body to every cell, every moment of life. Remember too that the heart has coronary arteries that have to get its share of oxygenated blood and have deoxygenated blood moved away. So the right coronary artery, we see the left coronary artery, the anterior interventricular artery, and how it wraps around the heart muscle. And it's going to receive its blood flow or its blood pressure during diastole. All the other cells in the body receive their oxygenated blood during systole, but the heart only gets it during its resting phase, its quick resting phase during diastole. So you can see that if a person has coronary artery disease and their heart is beating very fast relative to what their health is, that can be a bad combination because the heart is working hard to beat fast. It's needing a lot of oxygen. It's needing to get rid of a lot of waste. And this is where we can have problems with heart attacks and heart disease and heart failure and these sorts of things, because it's during this diastole phase that the heart gets its oxygenated blood. So spasms and blockages of the coronary arteries can lead to, in some cases, if it's sudden, just fatal results for the patient. So make sure you understand what it is and why it's important to not have tachycardia, especially if you get into a person that is more susceptible to coronary artery disease. So some of the things that can lead to heart muscle not receiving enough blood are atherosclerosis within the coronary arteries. That can lead to angina or angina pectoris, which is going to be a strangling, is the word angina, just below the sternum. And that can lead to an acute myocardial infarction and then death for the patient. So take a moment to study these pictures, have them memorized so that you can see the effects of where these emergency meds that we're going to talk about have their use. Sometimes those plaques can then rupture also. So again, angina is from the word to squeeze, and it's just under the pectoralis muscle, and it's just shortened to the word angina. And men can have different symptoms from women. Women and men can have the same, but men will describe angina as chest pressure, crushing chest pain. They can be sweating or having diaphoresis. There can be a heaviness, tightness, fullness, squeezing, and then severe anxiety is produced because the person pretty much knows what's going on from this intense pain, and especially with angina and heart attacks being in the news so much with people and maybe family members or friends that have suffered this. Pain can also radiate to the jaw and to the teeth. So here's some early warning signs in men. Women, it seems like they're used to a little bit more pain than we are as men, but there's unusual fatigue, sleep disturbance, shortness of breath, indigestion, and anxiety, but that can be produced by a lot of things. But again, women can still experience the same effects and symptoms with acute angina as men can. There's that plaque in the coronary artery that has just prevented oxygenated blood, and the heart muscle will then die. And it's a permanent death. It can't be resuscitated. That's why when somebody has a heart attack, we've got to quickly get them into the ER. They're going to have a CT scan extremely quickly, and then they're going to go into the cardiac intervention lab to have that plaque opened up, removed, whatever, so that that heart muscle doesn't continue to die. The same thing comes in treating, I know it's not in this course, but in treating acute stroke so that the brain tissue doesn't die. We have that same, what they call the golden hour, to get the person into some kind of intervention very, very quickly. So this would be a call 911 emergency and activate your local emergency medical system or EMS. So one of the first drugs, not covered in this part, but we talked about in part 1, is to give the patient a ton of oxygen. It should be one of the first drugs you think of. Again, as we're not covering it in this section, but you got it in part 1, so we can get oxygen to all the vital organs. I would use a simple O2 face mask. It's going to give enough FiO2 to get the patient oxygen just as quickly as possible. Remember, it's going to create an FiO2 that's probably 50% or greater at 6 liters per minute of oxygen flow. Remember, we're breathing at room air 21%. So we're giving the heart and all the organs a lot of oxygen so that they can maintain life. So I would go with this mask again. Or if you've got a non-rebreather oxygen face mask that we talked about in part 2, then you could go ahead and use it at this point. It's going to give an FiO2 at least at about 100%. I wouldn't use a nasal cannula, and if you had to, you could use the bag mask valve. But this is for a patient more that's not breathing that you would use the BMV, the bag mask valve. So let's talk about aspirin and nitroglycerin. Notice that they're in your proprietary emergency drug kit, but that's something that you can have in your custom kit that you've created for your office. Aspirin's sole role in the early treatment of angina or suspected myocardial infarction is that, as we talked about, there's going to be plaque buildup that's going to cause stagnated blood in the coronary artery. And with stagnated blood, we get platelet aggregation. We see that, and you'll see with some of the lectures on stroke, that stagnated blood sits there and it's not moving or barely moving, and clotting will occur. And those clots can dislodge and then either block the coronary artery or, in the case of the brain, go up the blood vessels to, it finds a very narrow blood vessel in the brain, an arterial, and it will block it and cause death of the brain tissue beyond the clot. So what we see is that with platelets, that they will adhere to the wound in the stagnated blood, they'll aggregate, and then they'll cause a clot and cause complete occlusion. So it can occur anywhere along any of the coronary arteries. So aspirin attaches to platelets, and it irreversibly binds to the platelets. So it's going to prevent the clot from stabilizing and forming into a major clot. So hopefully other arterioles going to the heart muscle are going to then take over. We're not going to keep that from being blocked. We're going to hopefully work our way around it. Or if it's a small enough clot and we've caught this as early as possible while we're treating our urgent or nearly emergent patient in the dental operatory, that we have stopped platelets from forming and adhesing and causing the clot. So the platelet's lifespan is about 7 to 10 days. By that time, this person's going to have been for coronary intervention in the hospital. And there's your dose for aspirin. If they take one by mouth, a chewable baby aspirin is 81 milligrams. And you would just have them chew one of those, and you'll be done with that part of the emergency procedure. Let's talk about nitroglycerin's role in the early treatment of angina pectoris. This is going to be, again, where we've got a coronary event happening. It could be either angina or it could be the beginnings of a myocardial infarction or an MI. So nitroglycerin is going to relax the veins and, to a lesser extent, the coronary arteries. So the coronary veins and the coronary arteries. Of course, we want them to do their work on the arteries. This is where we would apply a nitroglycerin tablet underneath their tongue. So if we've relaxed that endothelial muscle of the coronary arteries, it's going to hopefully improve blood flow with that highly oxygenated blood for that oxygen that we've already put on the patient with a simple face mask or a non-rebreather face mask. So we're going to dilate that vessel, and it's going to dilate the arterioles everywhere, so the person can get, and probably will get, a throbbing headache and then a drop in their blood pressure because of the relaxation of the arterioles. Remember, from some of our other lectures, you'll see, carry this over to those lectures, that the arterioles are going to be the main determinant of our blood pressure in our entire body. So when we've dilated those, we've dropped the blood pressure unless we increase the heart rate a little bit or give a vasopressor. So this person has that golden hour then to get to the hospital. So you've given them aspirin and you've given them sublingual, under the tongue, nitroglycerin. It can also be given not only as a quickly dissolving tablet, but as a spray that goes underneath the tongue. So for cardiac life support, when you've had your ACLS, this is applied for a person with chest discomfort, and you follow the protocol, call EMS, and these can happen all at once with your trained personnel. Call EMS, apply oxygen, give the aspirin, the baby aspirin, have them chew it, and then they can also swallow an aspirin, and then nitroglycerin underneath the tongue. You can see the dosages there. Either swallow the pill, chew the pill, goes down into the stomach and it's absorbed, or it can be given then underneath the tongue. Let's talk now about sugar, glucose. So the role of glucose that we've talked about, you'll see this in some of your other lectures with us, is it's the fuel for the chemical reactions that are eventually going to synthesize the high energy phosphate bond that the cells use as fuel to make ATP, to make things such as musculature move and all these sorts of things. You can see that glucose is involved then in the addition of a phosphate group to adenosine diphosphate to make adenosine triphosphate. So the pancreas, insulin, glucagon, diabetes, and blood glucose levels I want to go through with you now. Remember that the pancreas secretes digestive enzymes into the small intestine, but the big thing is it secretes insulin and glucagon directly into the bloodstream. So insulin, as I remember from school, brings glucose in to the cell. So insulin, and glucagon brings glucose out of the cells. So the glucose is gone from the cell. So that's the way that I have remembered that. Insulin is made in the beta islet cells of the pancreas, in the islets of Langerhans. It has 2 amino acid chains, just for you to see it. I know you haven't seen it in a while, but just kind of look at it, and then you see with all these different amino acids that mistakes can be made along the way, and that there can be some changes in the structure of the insulin. And here's just some pictures of the islets of Langerhans, and you can see the cells that then make the insulin. The insulin performs storage of glucose in polyglucose or glycogen in the liver, and it stores it in cells. And it also then creates fatty acids from that excess glycogen that's stored in the liver and stored in adipose tissue, which is the problem with overweight and morbid obesity in the country. Just a review of the 2 different types of diabetes. It's called diabetes mellitus, and type 1 means that there is a total lack of any insulin that is made. I remember it with the 1 looks like an I, if you will, so there's no I or insulin being made in that type. In type 2, the tissues become insensitive to insulin. Even though it's created, the cells are, if you will, it's not an immunity, but they're just not as sensitive to the effects of the insulin. So we've got insulin that can be given artificially, and then we've got oral hypoglycemics. And Ozempic and Wegovy are also new drugs that are given along this way. In cases of hypoglycemia, we're going to want to give sugar, glucose in the treatment of low blood sugar. So the brain is permeable to the movement of glucose. It will cross the blood-brain barrier and then go to the cells of the brain that are going to command a high blood supply and a lot of glucose for fuel. It doesn't require any insulin to bring glucose into the brain cells. Normal blood glucose with fasting is 80 to 120 milligrams per deciliter. Notice it's not a milliliter, it's a larger unit of blood, so it's 80 milligrams to 120 milligrams per deciliter. So when blood sugars drop, usually 55 or lower for a patient, that is called hypoglycemia. And a lot of different things can cause that hypoglycemia, like extra insulin, too much insulin taken exogenously, their oral hypoglycemic dose, and also being NPO can be a problem. Beta blockers can cause hypoglycemia, as well as alcohol or ethanol. intoxication or liver disease can cause hypoglycemia. So the patient will have a lot of symptoms like confusion, headache, dizziness, sweating, weakness, nausea, vomiting, and even just fainting. If any of us have been hangry and felt this, you know what it feels like to have a low blood glucose. So they're going to need some prompt sugar in their bloodstream to get the sugar throughout the body, but especially the brain. So we can use such things as cake frosting, a tube of glucose. We can give them a sugary soda pop to drink. It's going to rapidly bring sugar into the bloodstream. And in your emergency drug kit, you're going to have a bottle of D50 that you would draw all of it out and inject it into your IV solution bag as quickly as possible. Don't forget to label the bag that it's got glucose in there. And I would give them the whole bag and be ready for the patient then to have to go to the bathroom. So the drugs can be given, the sugar glucose can be given either through the GI tract, you can be giving it IV and intraosseous. So you're going to want to have these people have their appointment just as absolutely early as possible. Be aware if they're hypertensive patients on beta blockers and people with liver disease. And try to schedule them the first appointment of the day so they can get back to their eating and drinking regimens to keep their blood sugar in check. And while you're setting up and inserting an IV, if you're doing an IV sedation, use the needle or do an insulin check with your point of care glucose monitor to see what their pre-op blood sugar is. If you need to at that point in time, you can add your D50 to the IV solution and go on with the case. So here is your quick and dirty drug cheat sheet. You can see that we've got aspirin, nitroglycerin, and sugar glucose right there in the middle of that form. Thank you, and we will see you for part 4.